Welcome to Healthcare Scrabble, and the four-letter word that's on the minds and lips of most healthcare organization leaders today, risk. The world of shifting, identifying, and managing risk has come full circle to providers, payers, self-insured employers, and drug companies. And when you think about award-winning risk analytics and technology, a major player is Verscend Technologies. Today, we have one of the most influential and powerful people in the business world of healthcare, Dr. Emad Rizk, President and CEO of Verscend Technologies. He's sharing his thoughts and insights right here on Red Hot Healthcare. Let's go.
3 alarm and 21 hours. All engines respond.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello, and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com. Dr. Emad Rizk joined Verscend in August 2016 and serves as President and Chief Executive Officer. The company focuses on data services, analytics, and advanced technology for helping its payers and self-insured employer clients to identify and manage risk and quality. Dr. Rizk began his career as a physician in healthcare academics and research, then transitioned into the business aspect of healthcare. He led health consulting at Deloitte, then became President of McKesson Health, and most recently, the CEO of Accretive Health. Dr. Rizk has been named one of the 50 most influential physician executives in the United States, the top 100 most powerful people in healthcare, and CEO of the Year on Transforming Businesses by AI Magazine. Managed Healthcare Executive also named him to its 25 leaders in disease management. Dr. Rizk, welcome to Red Hot Healthcare.
Thank you, Steve. It's a pleasure to be here, and thank you again for having me.
Well, it's great to have you on. I know we've talked quite a bit off air, and I've been looking forward to this. I know our listeners are going to really enjoy the time. And I'd like to just jump right in. Over the last 5 years, we've seen the initiative for disease management fading out. Population health, value-based care, that's now spearheading health reform. I'd like to get your thoughts on why you believe this happened.
Well, disease management was probably one of the earlier names that were given to care coordination in the past. And disease management programs have evolved significantly over the last decade, probably 15 years. And they now encompass a much broader and farther-reaching strategy. And we are now calling it, as you said so yourself, population health management or value-based care. Population health management has a lot of different definitions, and as you know, many folks around the industry have their own unique definition for it. But it does boil down to the ability to understand the clinical and financial risk across an entire population. And once you have that information, you take a informed and targeted action that is at a patient level to reduce that risk and to improve quality.
Gotcha. And really on a larger macro level, what type of significant differences, Dr. Rizk, do you expect to see over the next 5 years in terms of population health management?
Well, payer organizations, and probably as you remember, maybe 20, 30 years ago, pharmaceutical companies were the first ones to deploy these disease management programs. And they were really used more for education, and they were not as comprehensive as they are right now. The next step of these population health management programs are going to be utilizing multiple channels of communication versus that traditional call center. And then you will also see at the same time that the providers and the payers are going to begin to assume more and more risk. Risk will be shared across both providers and across payers on a sort of a population-based way. And then you'll begin to see also employers having a very high amount of their payment that impacts their profitability in terms of healthcare will also be engaging population health management with their employees and putting their employees at some level of risk to be able to be part of these programs moving forward.
Yeah, absolutely. Risk is such a big thing, and we're going to chat pretty heavily about that today. Let's jump into Verscend Technologies if we could. One of the things that I really was caught by when I went through the site and learned about the company was this motto that you carry, and it's strength from all sides. And I'd like you to talk a little bit about that, and then maybe how it applies to a few things, some of the challenges you're looking to solve, some of the solutions you have, and maybe some of the clients that benefit from them.
You started out our conversation today, Steve, by saying that there is this 4-letter word called risk. And risk has got so many different dimensions to it. And one of the unique aspects that Verscend has is it is very unique. I'm not sure of any other company, if not only just one or two in the market, that has what I call these 4 important pillars of healthcare. The first pillar is the fact that we could identify through data and through working with clinicians what is the risk burden of a patient. In other words, how sick is that patient and what are the multiple comorbidities that patient has. Comorbidities, for the folks that do not know, that is multiple diseases. So we have a way of identifying that, and we do over tens of millions reviews of records to make sure that we identify that population well. The second pillar is this quality outcomes. Are we meeting the quality outcomes? Are the hemoglobin A1Cs being checked for the diabetics? Are the folks that have had MI are beginning to get their beta blockers? Are we meeting the healthcare gaps that exist in the population? Third, we'll talk a little bit later about DXCGs, but DXCGs is really the cornerstone or the standard of care for risk stratification. And it's been many studies that have done it. It is one of the more sophisticated engines out there that looks at a lot of data and figures out what the level of risk a certain population has. And then the fourth pillar is this payment pillar, which is mostly for payers. Are we paying the appropriate amount to Medicare, Medicaid, duals, and commercials? We now have this 4 different views. I sometimes tell the organization we could see it from the north, the south, the east, and the west.
Right.
We see all sides in a very comprehensive way, this 360 view of the healthcare environment.
Gotcha. When you talked about DXCG, and you brought this point up, and you said we'll talk about it later. Well, now is later because that's on the top of my mind as well. That's been a major part of what your technology is about, and we're talking about technology that's been around for 20 years. I mean, this is pretty powerful stuff, and it's pretty long-lasting. So why don't you just dive a little bit, if you could, into what DXCG is, and maybe some key statistics on just how powerful it's been to the market.
Sure. It is amazing, actually, that we just celebrated its 20th anniversary, that it was actually founded that far back. And it was founded really as sort of a engine that understands risk models. They knew even back then is how do we properly understand the risk models that exist there. It started out in the 90s, and it was a partnership with CMS. And we worked together, and there's another model that's out there. There's really 2, which is CMS's. They also have hierarchical condition category, which is HCC models. There's been dozens and dozens of various studies that say which one is more predictive. They both are very predictive. Some of them are very strong in one area. Others are less strong in others. The Society of Actuaries have done a study, and they looked at about 38 million unique patients and benchmarks that's out there, and they found that the predictive ability, and this is the Society of Actuarials, of DXCGs continues to be one of the top performers, believe it or not, Steve, in the market still.
Right.
Now, obviously, we've invested a lot of money in it. We looked at a lot of things to make it more sophisticated, using pharmacy data, using sometimes a lot of clinical data. But based on really being predictive in the industry in terms of the depth, the validation, the breadth of scope of the model, and the utility of it in population health risk identification, DXCGs continues to be the leader in the market by far.
Yeah, let's chat a little bit about some of the other things that you're known for at Verscend. I know that recently you won the Best in Class award for your payer analytics and reporting solutions, so congratulations on that. However, I will say just on the other end of things that the population health management product that you had actually came in last with class. And I know that that particular arena in population health, as we spoke about before, that's looking to skyrocket to over $40 billion in the next 5 years. So all that said, let's tee up this question. Just a few things, if you could tell our audience about what makes your analytics solution just so powerful. And then on the population health offering, coming off of the results here, what do you think you might be improving on with that moving forward?
Well, first, I want to thank you for recognizing our first position in class. I really appreciate that. We've been one of the companies, over the last decade that has really paid a lot of attention to quality. I think quality was one of those things that were probably, it was just something that sounded good, Steve. Everybody, of course, we were going to get quality, but nobody put the rigor and actually the systems in place to really measure quality at a population level, at a patient level, and at a performance of a provider level. And this has been something that we've wanted to do for a very long time. So we put a lot of energy, especially in the last 7 or 8 months, investing into our quality products. So class, this was, I believe, their first time in looking at the payer quality analytics.
Right.
And not just across the whole entire segments. And we did win, I believe, by a good distance to the second or to the third. And what we're also doing is we're integrating a lot of our quality products with our risk products and with our stratification process. So we're able now to have, again, that strength from all 4 sides and making the quality much more specific to a disease and much more specific to an individual and much more specific to a provider, as I said so before. I do want to, as I said before, I do want to talk a little bit about the population health management. I think we were appropriately positioned for population health management. As you mentioned before, Steve, there's a very wide variation of what a population healthcare management company is. It includes anything from stratification and identification to on-site, to call centers, to intervention, to case management, to comprehensive social work. And so class looked at it in a very comprehensive way. We actually only do 2 parts of that wide equation. We do the stratification and identification better than anyone, and we measure the quality outcomes. Those are the 2 bookends. Everything in the middle, we leave it up to our customers to do, not us. And so I actually think that class was very appropriate in doing this. We're going to continue to stay focused on that. We are not going to go into the services part of population healthcare management. We're still going to be on the software and on the analytical side of it.
Now, do you think that moving forward that might hurt Verscend in its positioning with other competitors, that you're going to stay on the bookends? Or do you think that the way you have it positioned now like that and leaving the middle pretty much open for other vendors and other technologies to come in and piece in, do you think that's the better way to go moving forward?
Yeah, it's a good question. I think it's more like the intel inside. The population healthcare management space is so crowded right now.
Yeah.
And everyone is in it. But we have to go back to our core. Our core, Steve, is we're a technology company, we're an analytics company, and we are a data and software-driven, innovative organization. And so if we focus on the stratification and the identification, and we focus on the quality outcomes, which, as you said, class put us in first place, those are the areas that we are going to be strong. And then other organizations that do the full end-to-end can use us.
This is Dr. Steve Ambrose. As a healthcare influencer, I'm in contact with some of the brightest minds and most powerful leaders in the industry. But my best effort comes from outside the booth. Knowing how to engage patients is an art, science, and philosophy that I know very well. I'm a hired gun that brings expertise to healthcare organizations of all types. You've heard my words. Now read my thoughts on my free white paper called The 7 Mistakes Made in Patient Engagement. Just go to redhothealthcare.com/learn. That's redhothealthcare.com/learn. While you're on the site, dive into my consulting and speaking services and schedule an initial call. You won't regret the uniqueness, benefits, and results I can deliver for you. And now, back to the show. Let's shift gears for a second, Doctor. And I listened to a recent talk that you gave at UC Irvine, which is just down the road from me here. I'm in Manhattan Beach. And you stated in that talk that to improve healthcare, consumers, providers, and payers all have to work together in a better way. With a shift coming, obviously, to value-based care away from fee-for-service, there's also fast-rising financial burdens that are coming on consumers, coming on patients in the forms of skyrocketing premiums, out-of-pocket payments, and deductibles. So that's something that I think has been largely ignored by most of the healthcare players today, especially when they start talking about lowering their cost. We have to lower our cost in healthcare, but unlike most existing consumer markets in America, it's not really a matter of competing against each other based on quality and price to the consumer. So while they lower the cost, nothing's really being mentioned about saying, and after we lower our cost, we're going to pass on lower and more affordable pricing for care and coverage and drugs and that sort of thing. So do you believe that healthcare services and coverage and drug prices really must come down in pricing?
Yes, but it's a much more complex answer to that. What we've really done over the last few years, besides just prices going up, it has also been prices are going up, but there's also been a great deal of shifting. And you mentioned that earlier. We shifted a lot. So employers shifted some of the risk to the consumers. The payers shifted some of the risk to the providers. The providers' health systems shifted some of the risk to the physicians. So generally speaking, I think we've just gone a little bit out of control in terms of this level of shifting. And I think it's good. We're in the first stages of it, maybe the second stages, but now we have to get all that shifting to be aligned and start to be accountable. And this is where I'm very different than I believe a lot of my colleagues. And it's an area that many of us have different opinions. I do think that potentially pharmaceutical products should have a value-based pricing. If there is a drug that does get discovered that will reduce hospitalization, that will reduce infection, that will reduce death and comorbidities, then I do think that if there's a value to it, there should be that. But if it's another one that's another Me Too drug that is going from maybe 2 times dosing to 1 times dosing, that probably should not get much of a premium.
Right.
But back to, if we're going to lower the absolute cost, it's not going to be just the pharmaceuticals, although we have a very big curve coming. I think as you look at a lot of the data out there, the specialty drug piece is huge. And that is another big wave that's going to be coming and has started. And they're expensive. They're over tens of thousands of dollars, if not even more than that. What we really need to do right now is to start to share data, really, truly share data across all segments. We've gotten to the realm of a little bit ridiculous here. We've not gone back to pure cost of the goods that we're preparing. What is the value of them? And I still think, even though we're shifting and we're getting into value-based reimbursement, and many people are saying that it's accelerating, but back to your point, is there needs to be transparency in pricing. And if there's transparency in pricing and transparency in data, then we can begin to make a real impact on the total cost of care.
Yeah, and by the way, I'm not saying that consumers don't play a role too. I mean, clearly, with chronic care being at 75% of all healthcare payments, people really have a role to play in making things more affordable. But the simple fact of the matter really is, Doctor, that at the end of the day, in the last 50 years, the average cost of products and services in this country over 50 years, the pricing has gone up 8 times. The pricing of healthcare has gone up 274 times. That's huge. I don't see, unless changes are made, I don't see it being a long-term sustainable health system. So hopefully what you're saying is true, that once we do start sharing the data, and with the advent of value-based care, it's not going to be just a matter of fee-for-service where it's just bill, and overutilized because you know you're going to get paid for it.
Correct. And also the one word that I think is important is transparency. Some level of transparency. We are still one of the only segments or one of the only industries that does not leverage technology as much as others.
Well, there hasn't been a need to. There's been no need to, because when it's fee for service, there's a predictability in getting paid. I mean, that's the whole point of the fee for service, which I know you agree on, which is, why would you? Why would you need technology when you don't really have to if you're a hospital or health system or drug company?
Correct. And I think that's where once we get to that more value-based pricing, you will start to see people are going to use more natural language processing, more machine learning, more artificial intelligence. Our processes in healthcare are antiquated in many ways. Just think about the fact that you could go anywhere in the world with a credit card, and at that moment, that chip can identify everything about you, who you are, how much money you could take out, and it's tracked. When was the last time you've been to the hospital and you gave that chip and they figured out which medication that you're on versus asking you 5 times?
Yeah. And you hit on it so well in that prior talk. It's business models. Like, why would the EHR companies want to make it transparent? Why would they want to make it unsiloed? I mean, their vested interest, right, on a business perspective, is keeping people on their system and keeping people locked in. So, one of the guests that I just had on recently, a doctor, was a gentleman by the name of Jitin Esnani, who, I'm not sure if you know him. He is the executive director at Commonwealth. And, the business models have to change because ultimately they may help for business. They're just not helping for a healthy, ongoing, sustainable system.
Correct. Agree completely. But keep in mind also, just Steve, one thing is, I'm not sure that I would hold the electronic medical record companies solely, responsible for this. I mean, there's much accountability to be spread around. Mm-hmm. The fact, the EMRs have also helped us digitize a lot, although we still have over 70 to 80% of still undigitized information, where we still have to kind of get into a digitized format. There's much blame to spread, and there's much accountability to put across the entire healthcare ecosystem.
Yep, I completely agree with you. Completely agree with that point. And, just touching on this one last question I want to get in with you here, which we talked about this off air, but I think it's one that the audience will find interesting. You referred to a 2014 Commonwealth Fund study in one of your talks that I listened to, and talks about 25% of all hospital spend relates to administrative costs. And I know that when we talk a lot about AI and the sexiness of artificial intelligence and, NLP and machine learning and cognitive computing and Watson, a lot of it seems to really be on the clinical side. What we don't hear a lot about is the possibility of artificial intelligence push into the administrative processes and systems. We're talking about cutting costs in healthcare and the importance of it. We know the 2 biggest costs really in any business, healthcare not excluded, is going to be salaries and benefits. Do you believe that with the advent of this cost cutting needing to be done for value-based care, that on the administrative end, health systems and hospitals and other healthcare companies should actually be looking to not only put in AI, but maybe replace some of the human workers that are involved in administration to really drive down that cost?
They would need to do both of leveraging technology, not just AI, but leveraging technology to automate many of the processes that they have, but they also need to improve sort of a lean or a Six Sigma process that they have to continue. If you look at when you go on a plane and look at the safety record of a plane, sometimes the pilot and the co-pilot have never flown with each other, but each of them come on board and there's a checklist, and they both go through that checklist, and that checklist is quite automated, and it's a very efficient process. They go through everything that they have to go through, and then we're ready, and then we go off. We don't have a similar process, but granted that we have a variable process because it's medicine. But if you look at the time when we started to create integrated delivery systems, which was supposed to drive cost out, it wound up driving cost up,
Right.
because we added more layers into our organization. So I think it's a combination of leveraging the technology, but also allowing that technology to be able to improve your processes.
Yes. And, some of the things we talked about before, the buzzword of population health management. Here's another buzzword that's being thrown around quite a bit. This is one I actually consult on, but that's consumerism, healthcare consumer. And this idea of now the people out there who aren't patients needing to be activated as patients. I'd like to get your thoughts on this if you could, Doctor. Maybe give us some thoughts on where you feel payers and even providers really, in your opinion, need to make the greatest change for consumers.
As many people say that all roads sometimes lead to Rome, in healthcare, it seems that all roads always lead to transparency. And the interesting thing is consumer transparency in healthcare is a perception, but not a reality. Consumers really do not have a great deal of transparency in terms of where the highest quality of care is on either a hospital level, a physician level, an outpatient center level, and how cost effective it is. For us to get to true consumerism is going to have to get, again, to a transparent system that exists, and the payers and the providers that do have that data have to work together and put the consumer in the center and say, what does this consumer who might be diagnosed with diabetes or congestive heart failure, what information does this consumer need to have? What are the clinical requirements that we need to educate him or her, and which I think we've done a good job in that? Who are the best doctors in their zip code that have the greatest outcomes? Who are the best doctors that have the best lack of progression of the disease? And who are the most cost-effective providers in that area?
Doctor, what's one thing that you believe that very few people agree with you on?
A hard question. I think the level of data sharing that I would like to have is probably not everyone believes is as possible or is as doable. I believe we should have a single patient record, which we do not have. And I think still many segments of healthcare, you could name them, whether they're payers, providers, physicians, long-term care centers, hospice, many of them keep the information to themselves. They do not want to share it because they believe that the sharing will be used against them. And so I do believe that this is an area where the private sector and the government sector, it could be policy. My view of level of data sharing is probably very extensive and high, and I do not believe that my colleagues would sign up for that.
Yeah, and I know just about everything about you. So when I do my research for guests, I go way back, and I think I went back. I mean, way back. I mean, I went back 10 years for you, and I can tell you that even 10 years ago, reading some of the online publications that you were quoted in, you were still banging that bell back in 2006, 2007, and that was way ahead of when people were even thinking about interoperability. You were talking about it. So I know that's something really near and dear to your heart, and something that you're never bashful about sharing. Let's finish up on the future for Verscend Technologies. Let's go out maybe 3 years, maybe give our audience what would be your priorities leading the company here, and what sort of solutions and initiatives you're going to focus on.
As I started the conversation, that we're unique with these 4 verticals that we have. It would be a very high priority for us to take those 4 and integrate them in a way that clearly creates a category of one. We take the risk, we take the stratification, we take quality, we take payment. It goes back to my comment in the very beginning of paying for value. When you pay for value, means that you understand the appropriate risk that you're taking, the appropriate quality outcomes that you're looking for. You are looking for the appropriate stratification to manage that population, and you pay based on that. And we now sit at over 120 million lives. I mean, that's over a third of the country, maybe 175 in the next 2 to 3 years. So we will have tremendous level of insight into the healthcare industry from those 4 dimensions. And so I believe that integration is in the forefront. That's number 1. Number 2, we will always put our customers first. So we partner very much with our customers. Outside of integrating our data, making our solutions best in class, but also making our solutions much more integrated, is becoming very good partners across all things, not just service and tools, but even across our service that we give. Our pricing should be fair and equitable. The ROI of our products should be basically best in class. In my entire career, that's what I always strived for. I believe you have to be first, and I guess if you can't be first, you could try for second. But I do believe if you're going to do something, we might as well be the best at it.
Well said, well done. Dr. Emad Rizk, President and CEO of Verscend Technologies. I want to thank you so much today, Doctor, for stopping onto the show here. Privilege and a pleasure. And I know our audience is going to get quite a bit out of this. So thank you, and certainly best of luck to Verscend and to you moving forward.
Thank you very much, Steve. It was a pleasure.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.